Welcome to AETCM, the emergency medicine channel.
Yeah, so I'll give you a case scenario. So we have got a pre-alert. A 50-year-old male was found unresponsive, and the paramedic have initiated CPR, and the patient will be here within another 2 minutes.
Okay.
So you are working in your ER on your duty shift.
Okay, so I'm the team leader. I'm going to assign the roles. Dr. Pretty, you'll take care of the airway. Dr. Shreya and Dr. Ebin will take care of compressions.
Okay.
Rishikesh will be in the monitors and defibrillator. And Dr. Ebin will be on the monitoring and documentation. And Dr. Jarin will be in IV access and drugs.
Okay, so the first step, what you have done, now you have assigned the job responsibilities now. Okay, so anything else that you wanted to do during this 2 minutes of time?
We can load the drugs.
Okay.
And
you can make sure that all the airway equipments,
are
whatever is required for your resuscitations, are kept ready. So it will be available in the ER, so you have kept ready. So now the patient has arrived and he is in front of you. So CPR is ongoing.
Okay.
So I have connected the monitor.
Okay.
So monitor has been placed.
So I'll be securing the airway.
Okay.
So now monitors connected. Can we see the rhythm, please? Please stop CPR, Dr. Shreya. It is showing VF.
Okay.
Continue CPR. It is a shockable rhythm. We can charge to 270 joules, maximum joules.
I have selected maximum joules of energy.
Put the jelly.
Jelly applied. So stay clear.
Stop CPR.
Stay clear.
Resume CPR. So the monitor was initially showing wide complex irregular tachycardia, so it is VF and it is shockable rhythm. So during the next rhythm check, Dr. Pretty can secure the intubation airway, and you can IV access and drain for ABG. And the CPR should be 30:2 ratio, 30 compressions and 2 breaths. And you can also load adrenaline now. Don't give, just load the adrenaline.
1, 2.
So now what we are doing, we have had a patient who had come with the first shock we have delivered, and we are continuing the CPR. So after how long we need to reassess the patient?
Every 2 minutes we have to reassess the patient.
Or after 5 seconds of CPR. So 1 cycle is 30 compression followed by 2 rescue breaths. Imagine that we have crossed the first 2 minutes.
Okay. Now we'll start a rhythm check. Stop CPR. Monitor still showing VF. Continue CPR and charge for 270 joules.
Please second defibrillation. Please stay clear. Yes, second defibrillation.
Continue CPR. You can give injection adrenaline 1 mg. IV start followed by 20 ml bolus. And next rhythm check you can intubate.
Adrenaline 1 mg, 1,000 given.
1, 2. During this time, we will be intubating the patient and the airway is secure.
So what change that you wanted to make when an advanced airway is in place?
Every 5 seconds we can give a breath.
Every 5 to 6
Not
seconds?
like 30:2.
Okay. So no need to stop compression after 30 compression. So you can continue at a rate of 100 to 120 in a minute, and every 6 seconds you can deliver 1 breath. Okay. So meanwhile, anything else that you wanted to do?
We can get the VBG result.
Okay.
And we can also change the compression if they are fatigued in every 2 minutes.
Okay. And we have not done that.
If you are fatigued, we can, Dr. Bin, take over the compressions.
So during compression, what you wanted to look for?
We have to know the high quality CPR, that is around 100 to 120 per minute, and more than half of the chest depth should be the
So how will you ensure that you are giving a high quality CPR? What is the ideal way? What is the recommendation? What are the 2 ways by which say he is delivering a high quality CPR?
One is ETCO2 and one is the compression band.
You have to have a feedback device. You should have a feedback device or ETCO2. If it is less than 10, you should improve the quality of CPR. Okay. So imagine that we have crossed 2 minutes.
Okay.
So can you just brief what all things we have done, Dr. Evin?
we had initially initiated on compressions, and the first rhythm check showed ventricular fibrillation, and we had continued CPR and charged the paddles, and we had given the first defibrillation. And after that, again, compression was continued, and the second rhythm check also showed ventricular fibrillation. And we had given the next shock, and followed by injection of adrenaline, 1 mg IV was given. And after that, again, continued on compressions, and this is our third
Rhythm check. Anything that you want to do before the third rhythm check? You want to tell him?
Amiodarone can be loaded. 300 mg amiodarone can be loaded and kept.
Okay.
So recharge the defibrillator.
You are pre-charging the defibrillator.
Okay,
Excellent.
okay.
Why you want to pre-charge the defibrillator?
To delay the message delays.
To decrease the pause. Okay. 2 minutes over.
Dr. Debin, please stop the compression. We'll check for rhythm. Now also it is VF.
Complex irregular tachycardia. So stay clear away from the patient. Third defibrillation, deliver.
Continue CPR. Dr. Jorin, can you give amiodarone 300 mg IV stat?
So we have the blood gas result. Can you just tell the blood gas result?
301 g amiodarone given.
blood gas result shows potassium of 6.2 with a bicarb of 12 and pH of 7.02.
So most probably it will be a hyperkalemic arrest. So we can give anti-hyperkalemic measures. That is, first is injection calcium gluconate 10% 10 ml IV bolus should be given, and then GI bolus, that is 25% dextrose with 8 units of insulin ectrapid.
Okay.
So can you give injection calcium gluconate 10% 10 ml IV bolus?
Injection calcium gluconate is 10% 10 ml given.
And GI bolus also, can you just start on the infusion?
GA bolus started.
Okay. 2 minutes we can presume to be
Please
over.
stop the compression. We'll see the rhythm.
What is the rhythm?
Now
that
it is torsidis depoindus.
Okay.
So start compression. We'll charge and we'll please give injection magnesium sulfate 2 gram IV bolus.
Okay.
Injection magnesium sulfate 2 gram given.
We'll shock.
Fourth shock delivered right now.
Fourth defibrillation performed.
We can give
Done.
amiodarone 150 mg IV stat. We can give.
Okay.
Injection amiodarone 150 mg IV given.
Given. Okay. So we can just debrief, or you want to look for anything else? As you just want to presume that it's a hyperkalemic cardiac arrest, or you wanted to think that you have multiple causes. We always don't presume that it's a single cause that is causing cardiac arrest. You have to definitely go back and get a history. We need to know what exactly has happened to this patient, whether it's an ACS or whether there was any chest pain prior to that. All those things we should be looking into. And you have to look for the 5H and 5Ts. All 5H and 5Ts, keep that in your mind. Okay, presume that we have completed the 2 minutes.
Please stop CPR, Dr. Shreya. We'll assess the monitor.
Rhythm,
We have get an organized rhythm. Can you please check the pulse?
pulse. There is an organized rhythm and pulse is there. So what we have done, we have achieved
achieved ROSC.
return of spontaneous circulation.
Circulation.
So what you want to do right now, once you achieve the return of spontaneous circulation?
Post cardiac arrest care.
Yes. So what are the important things in the post-cardiac arrest care? You can tell me.
We have to prevent hypoglycemia, hyperglycemia.
So let's start with the ABCD.
Yeah.
Airway.
Already secured with
Secured. So what's the
intubation.
target that you want to set with the saturation?
More than 95%.
94 to 98% is what is recommended. Then
And prevent hypercarbia.
prevent hypercarbia, maintain normal PCO2.
PCO2.
Coming to the blood pressure,
BP should be between means not
a systolic blood pressure above, a MAP above 65,
65.
or a systolic blood pressure above 100. So that is a recommendation. So you have ALS recommendation, ACLS recommendation. ACLS say MAP, ALS say SBP. Then you have to start for you have to give the critical care treatment. Then secondary brain damage you need to look in for. Then what will be the next step that you need to do? 2LE DCG, very important to get a 2LE DCG, and you see whether the patient is responding or not. If the patient is not responding, you have to have maintained regarding the normothermia. So previously it was 32 they were saying, but now it is you maintain normothermia. That is more than enough. So maintaining of the normothermia is what is required. So we have a team ROSC. Now you can just debrief with the team members. You can get inputs from each one of them, and we'll have a conclusive remarks on it.
So we had got a patient with unresponsiveness, and BLS providers were initiated CPR from outside.
Okay.
So when he came here, we started on CPR, and rhythm checking was first rhythm check was showing a wide complex irregular tachycardia, which is VF, which is a shockable rhythm. So we initially gave a shock, and then we resumed CPR, and then we had given IV access was already secured, and then after second shock we had given injection adrenaline, and we had secured the airway with intubation in 80 tube. And then third also was showing a VF itself. So we had given amiodarone 300 mg, and then the next rhythm check was showing torsadicity pointers. So magnesium sulfate was given. Also we had given amiodarone 150 mg, and anti-hyperkalemic measures was also given. And the next time we were shocking all the time, and after that we had got the organized rhythm with a central pulse.
Okay. So comments from each one of you. Dr. Shreya, anything that you think that could have been done better in the CPR? Anything that you feel within the teamwork? Or any challenges that you faced during resuscitation? Any comments from your side?
And the change.
Yeah, the switchover. After 2 minutes, there should have been a switchover, which got a little bit delayed. Yeah. But she also didn't say, because we are now doing it really for 2 minutes. That is the reason. And again, anything inputs that?
CPR coach, okay, sir, everything went have inserted CPR coach.
Yeah. That would have been a better. We would have, while the preparation, we would have kept a hard board beneath that. That would have been better. Pretty, anything?
All the things what we have done should have been verbalized more loudly, so that all team members come to know what we are doing.
Okay, that's fine. That's correct. Dr. Avin?
That closed loop communication we have to always
maintain. Okay. Vishnupriya, anything?
Sir, after 2 minutes, you might have checked the pulse.
Okay. Okay. After we were looking for the rhythm, but we were seeing wide complex rhythm, but there was no pulse check was not done. Okay, agreed. I mean, pre-charging the defibrillator, but I think before the second shock or third shock, Anagini was doing, that was a good thing. Dr. Jiran?
And fine, actually, cause for the hyperkalemia should be
we look for the cause for the hyperkalemia. Excellent. You have to always see why the patient developed hyperkalemia. So let me ask few questions here. So this was a scenario, it's a straightforward scenario. So ventricular fibrillation or ventricular tachycardia. So our aim is what? To deliver as early as possible defibrillation. So that's our idea. And what is the dose of defibrillation that you wanted to give?
Maximum, that's 270 to
200 joules for a biphasic defibrillator, or the maximum joules whatever is available in the defibrillator. I think one thing that when you're giving defibrillation, you have to be that clear shouting. You have to really be a little bit dramatic at that point of time. That has to happen during when you're genuinely giving the shock also. We know that it's a simulated environment, but Anagini was rushing and shouting it, but we have to be a little bit more dramatic, and everybody should be very clear that we are going to deliver the shock to the patient. Then, so that is the first thing. Then the next important thing, what do you do when this is refractory? So when you call that, the VF is refractory ventricular fibrillation. So what will be the time frame? You have to think that when you have given 3 shocks, and in between all the 3 shocks, initial to start with, you have given 2 minutes of CPR also. Still, the VF is not converted to a sinus rhythm. We can call it's still persisting as a VF. We can call it as a refractory VF. Why I am saying this? When you have a refractory VF, you have to keep in mind 3 things in our mind. What are the 3 things? One is the double sequential defibrillation. So, being a postgraduate, you should be aware that there is something called as double sequential defibrillation, where we are sequentially back to back. We are delivering 2 shocks. So where to keep that paddles is the question. So androposteriorly and androlaterally. So already we are keeping one here, and one in the front and one in the back. So ideally that will be done with the help of adhesive paddles. So that is the thing that you need to keep in your mind. Double sequential defibrillation. The next thing, the research is done. There are no major RCTs for it. Esmolol. Role of esmolol in refractory ventricular fibrillation. So that is one thing. 500 microgram per kilogram you can give, because there is increased sympathetic response. So esmolol is a very short acting drug. This is a quick acting also, which has got sympatholytic action. So that is the other thing that we need to consider. And third thing is a little bit difficult, but it can be still done in the emergency room. For a refractory VF, we have to think of
sympathetic ganglion.
Stellate ganglion block. So that is the one, stellate ganglion block with an ultrasound gated stellate ganglion block. So refractory VF, you have to think these 3 things is what we need to consider. as of the present evidences are available. So, and always remember that they look for the causes. And again, calcium gluconate, I don't agree with that dose for a hyperkalemic cardiac arrest. Maybe you need to give 2 to 3 times. If it's a calcium chloride, I would have agreed for a 10 ml. But calcium gluconate, you need to give a little bit more dose. And maybe bicarbonate, but he sets a pH of 7. So that rules out a bicarbonate infusion. But still, it's a hyperkalemic cardiac arrest. You can try bicarbonate, 50 milligrams of bicarbonate could have been given to the patient. And once the resuscitation is done, we have to always do the post-cardiac arrest care. 12 lead ECG, all those things has been discussed, and most key thing is that you have to find out the cause why we need to do a proper head to foot examination, a primary survey, and all those things. So any other comments that you have, anything? Fine. Okay, so we have discussed a shockable rhythm, and we just discussed briefly regarding a refractory ventricular fibrillation. Fine. Thank you.
Thank you, sir.